Welcome to Eye Contact. I'm Dan Epstein. I'm talking to Professor Cynthia Roberts about what's new in the field of corneal biomechanics. Welcome, Professor Roberts.
Thank you, Dan.
How has our understanding of corneal biomechanics evolved in the past few years?
You know, it's pretty exciting because corneal biomechanics used to be something that was in a laboratory that was of less clinical interest, but with the development of new devices that allow us to actually acquire biomechanical parameters clinically, it is coming into lots and lots of new uses.
Such as?
Well, you can use it for screening prior to refractive surgery for at-risk corneas. And at-risk corneas actually have not yet developed surface features that are characteristic of ectasia, but they have the underlying biomechanical abnormalities that may lead to ectasia if refractive surgery is done. So now these devices can be used in preoperative screening to prevent refractive surgery from being done on someone with underlying biomechanical abnormalities.
Is there already some evidence that they can prevent it?
Well, that is more difficult because iatrogenic ectasia is rare, and therefore you would have to look at many, many, many patients. And if ectasia is prevented, you won't know you've prevented it because the person has not actually received refractive surgery. But I think surgeons like to err on the side of safety and would prefer to maybe eliminate someone who may not have an underlying biomechanical abnormality as opposed to operate on someone who does.
How has our new understanding of biomechanics affected the diagnosis and treatment of ectasia?
Well, with the addition of biomechanical analysis, the clinical biomechanical analysis, one can detect keratoconus or asymmetry sooner. And what we have found is that keratoconus is not only a disease that generates asymmetric curvature, asymmetric elevation, and asymmetric pachymetry profiles, but also asymmetric biomechanical properties, where Giuliano Scarcelli has shown that the weakness is actually confined to the area of pathology, and 180 degrees away, one cannot differentiate that portion of the diseased cornea from normal. So by identifying these asymmetries earlier, the patients can actually be treated earlier with something like corneal collagen cross-linking and maybe actually prevent the need for grafts in the future.
How do the aura ocular response analyzers and the Corvis fit into everyday practice?
Well, these are actually complementary rather than competitive devices. Biomechanical response is actually a function of the applied load, and the air puff loads of these two devices are quite distinct. With the ocular response analyzer, the air puff is actually customized to each cornea so that an eye with higher intraocular pressure will receive a higher magnitude air puff, and an eye with lower intraocular pressure will receive a lower magnitude air puff. And what that allows is the measurement of the viscoelastic response of the cornea, which has been shown to be useful in predicting things like glaucomatous damage. Now, the Corvis ST, on the other hand, rather than having a variable air puff magnitude, has a consistent, constant air puff magnitude. So every single subject receives the same magnitude air puff. What this allows is when the cornea has reached its maximum deformation and the air puff is still increasing, there is whole eye motion, backward whole eye motion. And this really can be an advantage. And what we have found is that we can use this for evaluating scleral response, because a stiffer sclera will limit corneal deformation. So we really need to think of this as more of an ocular biomechanics assessment rather than just corneal biomechanics.
Looking ahead, what can we look forward in terms of future research?
It's really exciting. There's future research in the existing devices as well as future devices which are very close to clinical commercialization. With the current devices, such as the Corvis ST, we're actually doing research right now where we have determined that the shape of the deforming cornea can actually trap some of the air puff and influence the load experienced by the cornea. And this has allowed us to come up with really good separation between keratoconus and normal corneas, and that will actually provide more information as we move forward in time. For new devices that are really on the cusp of commercialization, there's one that's called Brion microscopy. And this device actually allows spatial differentiation of properties and can differentiate an asymmetric cornea from a symmetric cornea. The disadvantage is it takes a little longer to acquire the measurement, but the advantage is that it can give us much more information than is currently available clinically. And I believe that that is close to commercialization at this point.
The price is not going to scare the customers?
I have no idea what the price is going to be.
I do.
I think that's probably one of my jobs for this meeting is to try and figure that out, because you are not the first person that has asked that question.
Well,
but I think if they want penetration into the clinical market, they need to price it accordingly. So we'll see what happens.
This is now. Thank you, Professor Roberts. For more information, visit us at eurotimes.org.